Welcome to this overview of the basics of cardiac anatomy and physiology. In this video, we will be going over some of the fundamental concepts associated with cardiac anatomy and physiology using models generated from real MRI data. If you want to have a look at these models or use them within your teaching, a link can be found in the description of the video. Cardiac anatomy. In this diagram of the heart, we can see a number of key features. Firstly, the heart has four chambers, the left and right atria, as well as the left and right ventricles. There are also a number of key vessels to notice, such as the aorta, which feeds the systemic circulation, the pulmonary artery, which feeds the pulmonary circulation, and the pulmonary veins and vena cava, which return the blood to the left and right atria respectively. Between the atria and the ventricles are the atrioventricular valves. These are known as the mitral or bicuspid valve and the tricuspid valve. The AV valves are attached to the chordae tendineae, which are fibrous cords that connect the AV valves to the papillary muscles in the ventricle. Between the ventricles and their associated arteries, there are also semilunar valves, which prevent backflow of blood from the arteries back into the ventricle. The semilunar valve in the aorta is known as the aortic valve, while the semilunar valve in the pulmonary trunk is known as the pulmonary valve. The models being used today were modeled using real cardiac MRI data and can show how the ventricular wall moves throughout a cardiac cycle. In this model, we can see the anterior view of the heart with the left and right ventricles. The endocardial and epicardial surfaces are color-coded, with green and yellow showing the endocardial surface of the ventricle, while the blue shows the epicardial surface. Looking at the superior view, we can see the left ventricle in green and the right ventricle in yellow. The pulmonary trunk and aorta can also be seen from this view, with the pulmonary trunk being the most anterior vessel, while the aorta is the posterior vessel. These models don't show the valves or the atria discussed earlier in the video. The electrocardiogram of the heart represents the summation of the electrical activity that occurs within the heart throughout the cardiac cycle. The P wave occurs first, which represents the depolarization of the atria spreading down from the SA node. As the depolarization spreads down to the ventricles, we get ventricular depolarization, which corresponds to the QRS complex seen on the ECG. The segment between the S and the T wave represent the isoelectric period in which both ventricles are completely depolarized. The T wave itself represents ventricular repolarization. Together, the QT interval is representative of the time it takes for both ventricular depolarization and repolarization to occur, therefore giving the time of a total ventricular action potential. There is no wave to represent atrial repolarization, as this phase occurs at the same time as the much greater ventricular depolarization, which masks the smaller atrial repolarization wave. Heart sounds are produced by turbulent blood flow within the heart and its associated vessels, and occur in correlation with specific cardiac events, usually the closure of valves. The first heart sound is the result of the turbulent blood flow due to the closure of the atrioventricular valves. As the pressure in the left ventricle is greater, the sound is usually heard loudest at the apex of the heart. The second heart sound can be heard as a result of the turbulent blood flow due to the closure of the semilunar valves. The second heart sound is occasionally split when the aortic and the pulmonary valves close at separate times. This is thought to be due to the higher pressure within the aorta favoring earlier closure of the valve. The split widens during inspiration, but is usually clinically unremarkable. If the split is remarkably wide or narrow, this may be indicative of a number of pathologies. The cardiac cycle.
The cardiac cycle describes a set of changing conditions within the heart before, during, and after contraction. These phases are ventricular filling, atrial contraction, isovolumetric contraction, ventricular ejection, and isovolumetric relaxation. Ventricular filling. During this phase, the ventricular myocardium is relaxed and blood passively flows from the atria to the ventricles. The AV valves are open and the semilunar valves are closed. As the ventricle volume increases, the pressure within the ventricle also increases. This is generally the longest phase in the cardiac cycle and is associated with the time between the T wave and the P wave. As the ventricles fill, the pressure approaches that of atrial pressure, starting the next phase, which is atrial contraction. During this phase, as pressure in the ventricles approaches that of the atria, passive filling slows. Depolarization of the SA node and atrial myocardium, signaled by the P wave on the ECG, initiates atrial contraction. Contracting of the atria transiently increases the pressure within the chamber and allows a final injection of blood into the ventricles. This is usually responsible for the addition of the last 20% of the ventricle blood volume. The volume of blood present in the ventricle after atrial contraction and just before isovolumetric contraction is known as the end diastolic volume. The next phase of the cardiac cycle is isovolumetric contraction. Once atrial contraction has resulted in blood moving into the ventricles, ventricular depolarization begins, signaling the beginning of the QRS complex and initiating ventricular contraction. There is the closure of the atrioventricular valves to prevent the backflow of blood back up into the atria. During this, there is a brief pause in which the ventricles are still rising in pressure due to the contraction of the walls. However, there is no change in volume as both the atrioventricular and the semilunar valves are closed. This phase is known as isovolumetric contraction. Ventricular ejection occurs once the pressure in the ventricles has risen above the pressure in the arteries, resulting in the opening of the semilunar valves. This allows the blood in the ventricles to flow out and into the aorta if coming from the left ventricle and into the pulmonary trunk if coming from the right ventricle. Due to the differences in pressure between the two ventricles, the aortic valve opens slightly before the pulmonary valve, allowing the blood from the left ventricle to leave just before that of the right ventricle. The small volume of blood remaining in the ventricles following ejection is referred to as the end systolic volume. During this phase and isovolumetric relaxation, ventricular repolarization occurs, producing the T wave on the ECG. Here we can see the difference between ventricular wall thickness before and after ventricular ejection has occurred. While relaxed, the lumen is filled with blood and the ventricular wall is stretched and thinner. During contraction, the ventricular wall thickens, resulting in injection and a smaller lumen. For isovolumetric relaxation, as the pressure in the ventricles decreases due to the blood being ejected out, the semilunar valves close to prevent the backflow of blood back into the ventricles. As the ventricular wall relaxes, there is a decrease in pressure but no change in volume as both the atrioventricular and the semilunar valves remain closed. This results in isovolumetric relaxation of the ventricles.
The diagram of the heart used to present the basic cardiac anatomy was created by Byronda. Thank you to Nicola for allowing us to use her ECG and heart sound recordings, which were presented in this presentation. We would like to thank Dr. Miriam Skading and Angela Sai for their guidance and feedback provided throughout the course of this project. We would also like to thank Dr. Ayah Elsayed for her guidance in the modeling of the heart and for providing us with the models used in the project. A special thanks to the staff and students in the MedSci 300 class of 2022 at the University of Auckland for their feedback and support.